Well, I'll answer from the PA side. As far as PAs go, theoretically, we can do anything that our supervising physician can do. It's on the responsibility of that physician to assess the competency and skill of the PA before delegating the act. But once that's done, the delegation can be done, and we can therefore do anything that they can do.
I'll answer the NP. Essentially, it goes back to knowledge, skill, and judgment. So it's gone back at a college level. It says if you have the knowledge, skill, and judgment to do it, you are self-regulated to do it. So no, there really isn't a limitation as to what you can do. Does that make sense?
So for instance, if you're from an NP adult program and you're working in primary health care and you're asked to see a pediatric patient, a 5-year-old patient, do you have the knowledge, skill, and judgment from that preparation you had to see that pediatric patient? Probably not. So there's an example of a difference. Or if you're NP-PEDS and we're asked to see a 65-year-old woman with osteoporosis, do you have the knowledge, skill, and judgment from a pediatric background to see that person? Probably not. In primary health care, yes, because you're seeing across the lifespan. So you could see the pediatric patient, you can see the older adult, but within a primary care perspective, not in acute care.
I think the other thing, I'm just going to jump in, honest, I'm not jumping in a lot.
You can.
Yeah. Is primary care, I mean, I can suture lacerations that come in. Within my scope, I can do it. I haven't done enough of it to feel that I have the knowledge, skill, and judgment. So because I only work 1 day a week, I don't see enough of them, I don't do it. Could I? My scope will allow me to do it, but I have to say, you know, I don't know. I have to give it to somebody else.
I think that's no different from a physician. Your physician's got have the exact same situation. You have to say, can I safely do this? You say, hell no, I can't. And then you don't do it, right? That's
so
true of all people in healthcare.
Yeah, so it's very knowledge-based.
So what's the difference between the education that an NP receives and the education that a PA receives?
Is that generally the same?
Talk about, you could probably talk about NP education.
So as I said, the students that come into our program have been registered nurses for at least 2 full-time years. Most of them come in with probably 5 years to 7 years of practice in an area. In the program, it's a master's combined with the nurse practitioner program. So they come into our program if they're full-time for 2 full-time years, and they do some core nursing courses first around theoretical basis for nursing practice and advanced level. They have a course around evidence-based practice from a qualitative and quantitative research perspective. And we have a course around decision-making, theories around decision-making, how nurses make decisions. And then they go into their NP courses, and the NP courses are pretty much the same in the acute care program as the primary health care program. It's the focus in the population focus that's different. So they take advanced health assessment and diagnosis where they learn how to see a chief complaint, how to make differential diagnoses about that complaint, and how to rule in, rule out the differential diagnoses either through physical examination, diagnostic investigations, or other means in order to come up with a working diagnosis. They take the therapeutics course, which Ruth tutors, and that's where they're truly learning about not only the drugs that they're going to be prescribing, but also how to prescribe and how to be safe prescribers and know, once again, when to consult, when to refer, when you're... They also take a course about the roles and responsibilities of nurse practitioners, pathophysiology at an advanced level, and finally there's a clinical component called integrative practicum where they spend 455 hours in 2 clinical placements. Might be a little different in the acute care program now, but 455 hours where they're full-time with a preceptor. And the preceptors can be physicians or nurse practitioners, or a combination of both. More and more, because we have more NPs in the system, we can pair more of our NP students with NPs, which helps with role development and the social elements of the NP role, etc. So that, and then they graduate with a Master of Science degree and the NP certificate.
speak to the PA education in Ontario. The PA degree is a bachelor's degree. In Manitoba, it's a master's degree, but in Ontario, it's a bachelor's degree. And in our program here at McMaster, we require 2 years of university education, and then our program is a 24. If you get in with a minimum of that, it's a 24-month continuous program modeled on the MD program, McMaster MD program, and at the end of that time you get a bachelor's degree. And I could describe the courses, but it's the same essentially. It's modeled on the MD program. So I'll leave it at that unless you have more questions. And at the end of that, you get a bachelor's degree, and then you could be in a position to hopefully find a job and then to continue to learn on the job.
Yes.
Can you talk a little bit about how each of the three roles are funded? Who pays the NP, who pays the PA? And I know physicians are paid with a variety of different models, but I'd like, can you speak about whether or not physicians' income is influenced in any way by working with either role?
So I'll talk about the PAs then. Currently, there's a funding structure from the government. There's only been two graduating classes so far. So there's funding provided to graduates. Currently, it's not full funding, but there is some. And that goes directly to the employers. And then because I work for a hospital, I am actually paid by the hospital.
A salary?
Yes, that's right, yeah.
Yeah, the hospital you work at, are the physicians salaried in the emerge? Or are they paid for
There's
service?
kind of a mixed scenario in the emerge that I work at. There is a certain amount for a shift, and then there is additional, the term just left my mind, where they bill as well for the procedures and that they're doing.
Sure.
I'll let you talk about primary healthcare. I'll talk
Primary
about-
healthcare, we're salaried. Many of us, again, I can only talk to mine, are funded through the family healthcare teams. So the family healthcare teams apply for funding. Based on that, they get their funding if they want to for social worker, and they meet the criteria. We get a dietitian out of that. We get our diabetic educators where I am at. We've got 3 social workers. We have 5 NPs, but 3 of us are part-time, so it's really 3 NP full-time roles there. All of those come out of the budget for the family healthcare team, and they are given the salary for us.
And for the acute care MPs, they're funded under the umbrella budgets of the institution. So if a specific area would like an NP, they need to go through the steps of hiring anybody else and try and get that funding from another pocket in the hospital to go there. And then with the NP, it falls under a nursing budget at that point. So quite different in terms of funding for the way the 3 roles happen.
Can I just add to your
Sure.
comment? So the NPs in the hospital are not necessarily funded through the institution, it's through the program.
That's what I meant.
Yeah, so through the program. And to get a role, we need to make sure that the program has the funding for my role. It's through research or some research funding that my role is covered.
So that funding can be vulnerable at times.
Yeah.
Does physician income?
Physicians are paid by various methods, but the standard, the classic, is what I alluded to earlier, is if you have a billing number, you can then bill the ministry for a service. That is license to print money? You could say that. I mean, it's one way of articulating it. There's some truth in that.
You said you were speaking truths.
I'm trying to. I had this idea, maybe, I mean, it's a joke, but that NPs are physicians with their billing numbers. But if NPs had billing numbers, everything would be different. I mean, money makes the world go round, and how governments structure and finesse things. It is kind of, don't you think it's a little ironic the government gave nurse practitioners all this authority, but denied them a sort of a clear and obvious way to make a living, so they have to go through these mechanisms we're talking about. I mean, these are ideas. They're not. You could call them facts or not. Did the government do it? Give you what you want, but deny you the other part? Who knows what goes through the mind of government? People say to me, well, what is the government going to do about PA funding? I say, I don't know. You know, we're all just cogs in a wheel, but money makes things go round, and as Usha alluded to, there are different, there's a lot of patients, there's a lot of money, isn't it? What, 45 billion spent per year or something in healthcare in the province. There's a lot of money, but how it trickles down affects who gets jobs and how they're structured, so it's very complicated.
So just to add, I just want to add, what I'm not clear about is, given that a physician delegates medical acts to a PA, which is different from a nurse practitioner, can a physician who's on fee-for-service bill for what the PA does?
The answer to that, I think, is, my answer to that is, that is no different than the resident. I mean, in teaching hospitals, we're used to having residents. I can bill for what my resident does as long as I see the patient. That is the cardinal rule of OHIP. If you do not see the patient, you cannot bill. If my resident sees a patient in the middle of the night and sends him home, even after they talk with me and say, I say, yeah, send him home, I cannot, or I ought not, I will not bill, because that would be fraud. I never saw the patient. So that is the cardinal rule, and that is why I believe in a fee-for-service system, like Nancy's docs, they have an obligation, I think, to be careful with MOH, or OHIP, that they say, oh yeah, how did it go? Everything okay, Mrs. Jones? Did Nancy do a good job? Oh, good work, Nancy. Good, thank you. See you later, Mrs. Then no one can say you didn't see the patient. They can say you didn't see enough of the patient, but that's a whole different, there's judgment and then there's fraud, right? Now the problem gets into rostering. If you, rostering means that you actually, you're not fee-for-service, you get paid so much per head, per patient, per year. So now the patient comes in and is seen by the PA and is sent home. I believe if you were following the OHIP rules, you would do the same thing as I just said, but I think that the rostering rules don't necessarily require that, and people are even in the university, are not following that rule. So does that answer your question?
Yeah, it's just a concern, because one doesn't want to incentivize for or against the role of the NP and PA. I mean, I think we're all saying here, there's lots of patient care, there's lots of needs, there's a place for everybody, and it's great. But if there's a situation, and I'm not meaning to cast physicians in a negative light in any way, we all know within each of our professions that there are people who might be able to be financially motivated. And so if a physician is on fee-for-service and has an ability to increase their income by working with PA, as opposed to working with an NP, where that isn't likelihood, I have a slight worry that it could tip a balance about the makeup of a team that is now no longer being necessarily patient-driven as much as remuneration-driven.
Don't you have the sense, I'd be interested in your opinion, that NPs are by and large not hired by fee-for-service docs. They're hired by organizations that have a larger, broader funding structure, which would then allow for them to have an OT or a social worker or an NP and so on, whereas the fee-for-service docs, I'm guessing, don't hire a lot of NPs because they want the money in their own pocket. So then you can say, well, can the fee-for-service docs make money having a PA? And the answer is maybe so, maybe not. At the moment, we're in a period where the government is providing some incentive to get the profession going. Maybe they could make some money because they're getting some extra, right? They get to make that happen. I don't think it's going to be. I presume one day they're going to cut off that funding, and doctors are going to be on their own. I'm hoping we're going to see that by that. I may be wrong with that. I'm hoping that by that time, docs are going to say, I want a PA, I want an assistant, I'm willing to pay for it. We've done some surveys of there's a very small number of physicians in the province who have hired PAs, assistants, without government funding, without support. So we're very interested in what do those people think? And you say to them, are you making money or are you losing money? And the answer is, they don't know, they don't care. They haven't done the math. They haven't done the math because they don't care. They don't care because their quality of life is improved. And they're willing to pay the money to have an assistant to work with them. That's, I think, everything is, there's no single truth, but I think there's some truth in that some physicians out there are willing to have, they want an assistant, they're willing to pay for it.
I know that there's a physician that ended up hiring 2 NPs, same thing. Huge cohort of patients, wanted his life back. Chose to say, I don't care, here's the payment out of my pocket, just so that the cohort of his patients were looked after. So yeah, it's right there.
And I should just clarify, in my job, it's not, the physicians are not in a strict fee-for-service system. It's kind of this blended that's difficult for me to describe. There is perhaps a small advantage financially for them to work with me on a shift. But by far, the feedback I've received from the physicians I work with is, I make their shifts easier. They can get out on time. They know we're helping with wait times. They know that when something needs to be done, they can walk away and do something else, and I'm taking care of that. And it's more kind of the lifetime, the happiness. They can get home to their family, things like that, right?
Yes. It dates back to the Burlington randomized trial in 1974, which was the first randomized trial ever done of MPs, and the physicians were paid fee for service, and the MPs weren't regulated, and they paid the MPs out of their income, and they increased their roster from 3,000 families to 5,000 families. Everybody was happy, but unfortunately, MPs take more time off with patients and physicians. That's not unfortunate. That's part of the role they like. But the physicians were losing income, which is, after a while, gets to be a bit of a disincentive. We've seen all these patients, but in order to pay the NP of their salary, they were losing money. So that was one of the reasons that, among many other reasons, that we lost the NPs at the time, and one of the reasons that the government pays the salaries of both the PAs and the NPs now.
I think we could see. It's not impossible for the PA experiment to fail in Ontario based upon the economic structures, whatever the government does. We saw exactly that with NPs in the 70s. It's not impossible we're going to see it here. I'm not in the least pessimistic. The government has invested a very large amount of money in getting this rolling. Whether they will be able to continue it, it is an experiment. In the United States, though, they've gone from 0 to 80,000 in 40 years. I think we'll see that here, but the students who went into our program knew there was not guarantees. But how many jobs are guaranteed? Is your job guaranteed for life? I mean, whose job is guaranteed for life? There are uncertainties, so I think that having knowledge, having skills, gives you I like to say to the students or the graduates, you have marketable skills and abilities. You might have to go out and dig for them, but I'm optimistic that there will be opportunity.
And I would say the same for the NPs. There certainly has been a proliferation of NP programs across our country. Every province now has an NP program, with PEI being the last to come on board with a program, even though it's small and they're going through their hurdles. They have a program. So I would say just the very proliferation of the programs is a sign of interest in the role and commitment to the role from definitely a nursing perspective in terms of academia and supporting what's happening in our communities. And I was just going to say about the fee for service, certainly when the primary health care role came out, ER was the emergency room was one of the areas that was designated for primary health care NPs, and for the most part, the role failed for a couple of reasons. Fee for service was one of them, for the very reason that it took away income from the physician. But the other was that the NPs who went into the ER didn't necessarily have an ER background. And certainly the work that you had worked with Chris Basher on her PhD with her study showed if the NP had as an RN, ER background, and became an NP and went into the ER, it worked out much better. In terms of acute care, when we worked in acute care, unless the physician saw our patient as well, they weren't billed for the care. Now, certainly there have been problems with that, and certainly the Toronto Hospital, Toronto West, that whole went through a problem, and NPs were laid off after they had discussions with physicians not to bill for NP work that the physician hadn't seen that work. And so when it didn't correct itself, some acute care NPs lost their positions and clinical nurse specialists were brought back in, because then it was totally focused within nursing at that point. Whether the level of care was the same. You've lost an area of diagnosing, prescribing.
Thank you very much. So, question?
Yes, so currently we have a system where the government is helping to support the new PA roles. Has there ever been a time when the NPs were entering the system that the government was as supportive as bringing those roles in?
Well, certainly the family health teams, yes.
And in acute care as well? So I'm just curious why that has been, the PA support, the government support for PAs has been so strong in hospitals and in some of the other areas, but for the acute care NPs.
From my own point of view, I think it was the focus on healthcare reform in primary healthcare and to keep people out of hospitals. I think that certainly was when the acute care program started at 94 and then the Coupon program came in 95, the push and shove was really around primary healthcare and prevention, health promotion, etc. And that really took the forefront. And us as acute care NPs were kind of left in the shadows for quite a long time. Some may say still in some ways, but
I know that when we were students in the first class, the ministry actually told us about things like where were we thinking when we were done, the areas we would like to work, and the areas of medicine that we wanted to work. And we didn't know what they were going to do with that information. And in the end, what they ended up saying to us was, we actually thought before it was announced how the funding was going to work that they might strictly only fund emerged positions and family health teams. They ended up doing more than that, but I think it was the timing, wait times and emerges were so long that I think there was a push to head in that direction at least. So.
The other thing is, I think that with the PA role, it wasn't acute care or primary care. This was the role. It wasn't whether this acute versus primary issue didn't really exist or hasn't really surfaced yet.
and the education is to either.
Broad.
Whereas primary health care is primary health care education, NP adult or peds is what it is. So the educational structures are different in that way.
Just to add though, the neonatal nurse practitioner role, when it was introduced in the mid-80s, the government added a line item to the hospital budgets specifically for the NP role. So that is one instance where similar funds were made available specifically for it.
How long did that last? Just
Well,
for,
I think
just
it's-
for my own, is
I
it
think
still there?
Yeah, I think it's
I'm just wondering because we've seen a couple of programs go away.
Yeah, I'm
in
not
Canada,
absolutely
so.
sure, but I, as long as I kept track of it, the money was there.
Yeah. MAC is the only neonatal program right now.
But there are NMPs in all the
Yes,
tertiary level
yeah.
MSUs in Ontario.
So is there a better healthcare setting for PAs and nurse practitioners?
better healthcare settings?
Yeah, like do PAs, are they more effective in certain areas and NPs are more effective in other areas?
I think what Nancy said, it's matching skill level, competencies, right job, right place, right person, those kinds of things that really.
Yeah.
So theoretically, could a PA just work with the NP in one area and then work with the PA in another? Like, would they just be? I don't see like what the advantage of working with a PA would be. You could just interchange.
Could you try your question one more time?
Okay. So essentially, how come a physician in a family health team would hire a PA instead of a nurse practitioner? Or like in a family health team, how would those two roles differ?
Partly it's a matter of what kind of government funding support system you're in. Those things always distort reality, right, or control or influence reality. So I think that's partly an issue, how the organization gets funded. And then, of course, I mean, so I mean that's one thing. Then there's I have a talk which I wrote, which I haven't ever published or done it with it, which is related to this, and that was I took it out of this thing, but it's basically, well, which should you hire, a PA or an NP? I mean, it sort of relates to what you're saying. My answer is, well, you got to figure out what your job is, find the best person you can get for the job, the person with the right skills, the right personality that you can afford, that's available, right? And that's real world. I think it's not so much about title, it's about what job do you want and what job do you have to fill, what money do you have, who's available, and and you want somebody who's got the kind of personality who's going to fit in and make everything work. Like the great line, which I love to say, I'll say about consultants is, you know, what do you want in a consultant? The answer is availability, affability, and ability, in that order. So you want someone who's available first, affable second, and able third, right? So it's a good line.
And wasn't it, John, that the reason PAs were introduced is that we have physician shortage and we couldn't train as many NPs as were needed, and so we needed another member of the team.
The only trouble with all those things is that it could be true. That you just don't know, right? It could be that, it could just be that Josh Tepper had been in the States, his uncle was a PA, or but he tells the story how he was going to go to PA school, his uncle was a PA, finally goes into medical school, but comes back from the States with experience in PAs and MDs, and he says to the government, geez, this is a great idea, it really works, and why don't we do it? And for some crazy reason they say yes. I have no insider information. The standard argument is, oh yes, well there was a shortage of doctors and this is a way to give, you know. I mean, could I believe the idea is we can train these people in less time, get the same work out of them for less money? I could believe that. That sounds plausible, but what was really in their head, who knows?
I do agree with Alba though, that there is more demand than supply that there has been for the NPs. Certainly all of our NP graduates have no problem getting jobs when they're done. The problem is it's a limited enrollment program, so each university can only take 25 students. These students are, for the most part, 95% are women, they're married, they have children, they don't go full-time to the program. So 85% of our students go part-time, so they're longer coming out of the program. The government doesn't look at how long they take to come out of the program, they only look at what comes in. So they would know by our stats every year from our Cunnington program, the 9 universities, that what went in and what came out, there's quite a disparity there. But I think definitely it's true that we needed another healthcare provider of some sort to fill this gap.
You heard it from him, not from me.
I think it's
But something you said, John, about funding, and what are the income, what are the salary ranges for
My
PA?
belief is they're roughly comparable.
About the same? Okay.
The NPs are making roughly, when they graduate, $90,000 to $95,000 per year.
PAs are not making as much as that, I don't think quite, but they're in, I think it's in a
Same,
similar
similar.
ballpark, it's gonna come out roughly. Somebody you wanna comment, or you wanna not, you don't have to comment?
I think it is hard to judge because there was a minimum funding that was given, and then there have been a number of places who have added on top of that. So I can't say specifically, but it's probably a little bit less.
And I think the second year, they didn't have a minimum funding.
That's right, they do.
So, it's, but you know, to some extent, we're also, I mean, as I sort of alluded to in my talk, I didn't say the same words, we're talking apples and oranges. There are different skill sets or different structures, which I elucidated, and so there are apples and oranges, and there is going to be some money difference. I also cut out of my slide the idea that you should, instead of thinking of them as apples, we should think them as not as oranges and lemons, but as apples and oranges.
Well, and certainly across our country, there's variances in how NPs are paid, and certainly there's been a variance between primary health care and acute care in terms of salary, so.
There's differences in primary health care in family practice compared to one in an ER.
I lost my train of thought when about the apples and oranges, and because what I was going to say is that NPs almost certainly have got 10 to 15 years of experience on top of the PAs. Most of the PAs are coming fresh out of PA school, whereas the NPs have already been nurses typically for, let's imagine, 5 years, and then they've got 5 years as NPs. So there really are apples and oranges in terms of experience. And so people could say, well, PAs, they don't have any experience. Of course not. I mean, you could say that about any
novice.
Any novice doesn't have experience. Of course, it takes years to acquire.
What hours do you work?
I work a mix of shifts, so some 12-hour shifts, some 8-hour shifts, and it can range anything from day shifts, starting at 8, 10, noon. I work evenings, and then I do overnights as well. So, I work a 40-hour work week, but it's a mix of any of that.
Question?
My question is for both the PA and the NP. I know that the NPs have a little bit of a longer history than the PAs do in Canada, but I was wondering if you guys could just talk about your experience with the patients and how the patients perceive your roles within the field. And for the NPs, I guess if they've always perceived it that way, or if you've had some backlash in the beginning and they've become more accepting now.
My thought is, honestly, a patient does not care who is talking to them. You could be a clinical clerk, you could be a fourth-year resident, you could be a fellow, you could be a PA, you could be an NP. They do not care. They just want to know you're going to fix them. And, I mean, that goes back to when I was in nursing school as a student that knew nothing. Patients just will see you as the nurse. They don't differentiate. It becomes a title that they don't care.
I'd have to agree with that. By the time I'm seeing them, we all know what wait times are when they emerge. They're just happy to be seen. Many times they don't even hear the physician assistant when I introduce myself, and then they call me doctor, and we have the whole discussion. Sometimes they catch it and they don't say anything, and then I'm about to leave the room and they say, by the way, what's a physician assistant? I get, so you're like an NP all the time. But the ones that I really stop and pause are the ones that say, I didn't know we had physician assistants here, and then I say, how do you know what a physician assistant is? That happens sometimes. I still have to get used to that. People who actually know what it is I do.
I'm not clear as to whether the PA can prescribe medications, and if so, because they're not regulated, who's liable for those prescribed?
So in the hospital, we can have directives to write orders for medications. As far as prescriptions to be filled outside in outside pharmacies and that, there are PAs who have directives to write prescriptions, and as long as they're writing prescriptions for medications that they have directives for, this is okay. This is how this works. So I know that I know a particular PA in a family health team near Ottawa, and she said that, you know, in the beginning, she was getting calls from pharmacies saying, who are you and can I fill this? There was actually an article in the pharmacist journal about how it works and how it can be done, and so she would just fax off the article to them as well as a copy of the directive, and that was kind of the end of the story. It was able to be done.
But ultimately, the physician is, I mean, it's under the physician's responsibility. The physician is, the controlled act is the physician's controlled act, which he or she chooses to delegate, and you have to delegate such activities wisely and carefully because you're always liable, of course. By and large, I suspect, I could be wrong with this, that physician, I mean, PAs have no independent prescribing authority. They have no authority at all under RHPA. So
That is actually the controlled act that they're requesting through regulation, is prescription.
Is there a question in the back? Okay, so I understand nurse practitioners have been heavily involved in research and whatnot too. Is that going to change with PAs as well? I know PAs are more clinically involved with patients. Down the road, will PAs be involved with research and whatnot as well? Do you see that more of an integration down the road? Because I've read some articles and whatnot where nurse practitioners have played a key role in studies and systematic reviews and whatnot. Do I see that same role also being applicable in PAs as well, like from a research perspective, looking at the evidence, looking at formulating stuff with the PAs? We know it's more of a delegated role, so.
my feeling is that people go where the money is.
Yeah.
So if there's a job, a research job available, and the researcher wants to hire, a PA might well choose to do that as a day job than working nights in the ER. I think that's what you were talking about research about PA issues. So I think, and nurse practitioners also, they have a skill set to market, and they're looking for a job which is congenial and satisfactory. So I sometimes say to the students and the graduates, well, you know, if the job is